All right. Thank you for the intro. My name is Emily Harris, and I'm the Infectious Disease Program Manager with Chiricahua Community Health Centers. Today I'm going to be talking a bit about our Borderlands Infectious Disease Prevention Program taking place along the border between Cochise County and then the state of Sonora, Mexico. So this grant that we were awarded in December 2020 is really what made our infectious disease program possible. It was from the Pfizer Foundation and from Direct Relief as well. And the focus was on the purpose of establishing a binational infectious disease surveillance program in order to monitor and treat outbreaks across the US-Mexico border. The grant can kind of be separated into two different aspects. Drastically improving our internal infectious disease response. So what we do as an organization within Chiricahua, aspects of infection control measures in our clinics, how well we're performing as a clinical organization with our childhood, adolescent, and adult immunization rates, STI screening, to name a few. And then the second part, what I'll be focusing on most today, is the establishment of a binational infectious disease program. That's really addressing the lack of data and communication between the county of Cochise County and then the state of Sonora, Mexico. And I'll be discussing how we can improve the utilization of data as well as our collaboration in order to prevent and then treat infectious disease along the border. But primarily what changed after we were awarded this grant was that Chiricahua now had an infectious disease program manager, which is myself, to focus all of their time solely to infectious disease. We are now a team of 5, the infectious disease program, and I just think it's quite unique that 100% of our time, every time we're working, is just solely focused on the prevention and treatment of infectious disease. All right, and then I did want to start off with going over the organizational and community need. So really why we applied for this grant, what led to our application, and why we were in such dire need for an infectious disease program. So firstly, with COVID, when the pandemic hit, we realized that there were a lot of shortcomings in how we were responding to infectious disease. So this was taking place both in our organization, in our internal efforts, but also we were able to see this in our efforts out in the community as well. It really showed us the poor infrastructure that we had in place to conduct surveillance and to manage infectious disease for our patients and our community members. And it really also showed us that our response to COVID was entirely reactive. We didn't have an approach that was kind of taking place in a proactive manner. We were kind of left scrambling to get things in order. It just made it really clear that we were falling short in addressing infectious disease systematically. Going back to the point that I brought up on the other side, we didn't have a single person or one single team that was entirely dedicated to infectious disease. So during COVID, all of those responsibilities, the planning, the tasks, implementation of programs, all of that fell on top of staff who had a separate primary job that they were also needing to take care of and to worry about. We also didn't have an infectious disease surveillance system in place. We were generating very little actionable data to base our decisions off of. We weren't very data informed when it came to our response to COVID. So because of all of this, few meaningful actions were taken to monitor and then to improve in the prevention and treatment of infectious disease. So all of this was absolutely particularly worrisome given our proximity to Sonora, Mexico. So our service area is deeply impacted by the 100-mile border that we share with the state of Sonora, with one of our large clinical sites just 6 blocks away from the US-Mexico border. So our entire service area is impacted by both permanent immigration and then also daily border crossings, which occur in both directions. So while it was clear that we needed to establish an infectious disease program in general, we also realized that it was extremely imperative that this was done with a cross-border collaboration element in it, making sure that that collaboration between both entities on both sides of the border was really integrated into the programmatic fabric of the program we were about to develop. So this is just a bit of a closer look at the proximity between Douglas, Arizona, a main site that we provide services in, and then Agua Prieta in Mexico. COVID really made it apparent that border communities, they can't really approach and solve concerns of infectious disease without a binational consideration. When you're taking a look at infectious disease, it's really impossible to separate the two populations, regardless of if there's a physical barrier in place or not. On average, we have over 10,000 vehicle and pedestrian crossings per day between the two cities. And this is even with recent border restrictions on non-essential travel due to the pandemic. This shows us that there really must be communication and collaboration among leaders and professionals from both sides of the border if we're wanting to be successful in managing infectious disease in Cochise County. And then there's one last example that I wanted to go over regarding the need for the infectious disease program and why we had applied for the grant. Back in 2016, one of our providers in our pediatric clinic in Douglas had actually missed a diagnosis of a child who had Rocky Mountain spotted fever. Rocky Mountain spotted fever is a tick-borne disease, and it can be fatal to children if diagnosis is delayed or treatment is delayed. But if it is addressed in a timely manner, it can be treated with a common antibiotic. The diagnosis was completely off this provider's radar, and the patient actually ended up in the ICU in Tucson. And while all of this was occurring, there was actually a current outbreak of Rocky Mountain spotted fever in Agua Prieta that included 40 cases, and then also 6 deaths amongst children. Chiricahua, the county health department, even the CDC were all completely unaware of this current outbreak, which really showed how little American and Mexican health colleagues were communicating, and also how dangerous that could be, shortcomings that it could create for border communities and the patients that we see. The patient did survive, they did live, but had Chiricahua been alerted earlier, it would have been much less likely for this child to suffer from the illness that's otherwise completely curable with a common antibiotic. And then just to sum it all up, a quick quote, that infectious disease does not respect international boundaries. Border communities are one single community epidemiologically, regardless of any barriers that are put in place. Okay, and then like I mentioned earlier, the grant can really be split up into 2 efforts. So our internal response to infectious disease, and then secondly, a binational approach to infectious disease prevention. So I'm going to start off by going over our program goals and outcomes for the binational component of the grant. So overall, the Borderlands Infectious Disease Prevention Program is seeking to systematically prevent infectious disease along the US-Mexico border by taking a really proactive and data-driven approach to infectious disease prevention. So the goals include, first and foremost, establishing the program. So creating a comprehensive, sustainable, data-driven Borderlands Infectious Disease Program. And the program is definitely placing an overall emphasis on our immigrant populations that we serve. Secondly, the goal of utilization of data. So incorporating the use of the Medical Electronic Disease Surveillance and Intelligence System, which is really long, so we call it MedSys for short. Really incorporating the use of MedSys into our organization's capabilities. I'll go over more specifics about this system later on, but utilization of data also includes collecting data and analyzing reports on public health infectious disease data that originates in our own clinics. So data we're generating from our electronic health record system, but also surveillance data that's available in the United States and the state of Arizona, and surveillance data from Mexico as well. So we really have a broad understanding of what's going on in terms of infectious disease data throughout the entire service area. And then the third goal being the establishment of a binational program or a binational advisory committee. The goal of this committee is really to communicate on the data that's being generated, to share data, incidence rates, prevalence rates that we're seeing on both sides of the border. So in the States and then in Mexico, coming together, discussing the data, and then what steps we can take as a cohesive unit to both track, prevent, and then treat infectious disease, both in emerging diseases and then current diseases as well. All right. And then secondly, our program outcomes. The first one being prevention. So really improving our surveillance and prevention of both current and emerging infectious disease throughout the entire service area, and including the state of Sonora as well in that. Secondly, developing a preparedness plan for infectious disease. And this is definitely created in coordination with both our US and Mexico partners, the partners that sit on the advisory committee that I discussed in the previous slide. And then lastly, sustain effective communication and collaboration channels with US and Mexico partners that's specific to infectious disease prevention and treatment. So the primary goal, again, being focusing on sharing and discussion of infectious disease data, and then taking a look at how we can utilize that data to make informed decision in our response to infectious disease along the border. And then switching gears a bit into our internal infectious disease response, so the first part of the grant. This slide kind of outlines our goals and outcomes in terms of what we're doing internally. So our internal clinical infectious disease control, prevention, our proactive response to infectious disease. So first, focusing on our HEDIS measures. These are quality metrics. They include measures such as childhood immunization status, immunizations for adolescents, influenza vaccination rates, pneumococcal vaccination status in older adults, and then chlamydia screening in women as well. A few non-HEDIS infectious diseases that we're tracking are Rocky Mountain spotted fever, which is endemic to the area, and then syphilis infection, as it is increasing throughout our service area at the moment. So really improving these measures by performing clinic and community assessments that will help us identify barriers to screening, barriers to immunizations, particularly among our immigrant populations. So secondly, improving infection control, developing staff and community education plans, improving internal infection control practices via training. So these trainings would include going over infectious disease control and treatment, prevention among both clinical and non-clinical staff. So really involving everybody in the organization when it comes to infectious disease response. A few specifics of what this looks like, making sure that all staff are properly fitted and have adequate access to the proper PPE needed to do their job. Our procurement team is trained and equipped to proactively maintain the amount of PPE we needed. This is something that we struggled a bit with at the beginning of the pandemic, realizing that we didn't have enough PPE and we weren't really set up to provide that for our clinical staff given the times. Also ensuring evidence-based cleaning, disinfection, and universal infection control practices, again, being utilized by all staff. And then making sure that all these policies and procedures that encompass the trainings that I just went over are really clearly outlined in our policies and in our procedures. And they're in a place where all staff can easily access them and reference them when they're going about their daily jobs. So lastly, utilization of data, again, is definitely really important throughout the entire grant, either the internal response or our binational response. Internally, we're continuously collecting programmatic data and using that data to inform our program goals. So our program goals, decisions, the actions we take to respond to infectious disease within the organization. Analyzing our current data and then our past data as well, so that we're able to reflect and respond in order to improve on what we're doing. All right. And then there are two aspects that I went over as far as our binational infectious disease approach that I just wanted to break down a bit further, go into a bit more detail about. So the first one is the Binational Infectious Disease Advisory Committee, followed by going over MedSys. So the formation of our advisory committee, a few months after I was hired as the program manager, we actually hired an infectious disease binational liaison, and Alex has played an imperative role in forming the advisory committee. So she works day after day navigating the relationship between stakeholders on both sides of the border. She's really involved in the communities in the States and then in Mexico as well, bringing both entities together and really making sure that the key stakeholders that need to be at the table to address infectious disease are there. But when initially forming the Binational Advisory Committee, we did have to make sure that we were adhering to each country's protocol and then properly navigating political requirements. So in order to ensure sustainability of the program, we needed approval or permission from Mexican health authorities in order for them to allow their local doctors and their local leaders to participate in the program and in the committee. So Alex, our binational liaison, is very well known in both of those communities and really knew best how to navigate the politics of the situation, making sure that everything was lined up in adherence to political needs, that we gained that needed permission from the high level leaders in order for the local health stakeholders to participate in the program. Additionally, making sure that we were emphasizing the mutual benefit of the program for both parties involved. Obviously, having a cohesive and collaborative infectious disease response on both sides of the border helps keep infectious disease under control in the States and then in Mexico as well. So the first meeting, kind of going back to what I was saying in the previous slide, it was inclusive of all federal and state health authorities from Mexico. So the key stakeholders that were involved with granting the permission to local level doctors, local level epidemiologists, those who were participating in the project. So politically speaking, it was really important that we had the high level support in order to ensure sustainability of those actually participating in the advisory committee each time that we met. So then the following meetings after that initial meeting took place, those were the ones that included the local level stakeholders, the health personnel, the infectious disease specialists, health directors, all of those that were directly involved in the program's goals and outcomes. So in these meetings, everyone's sitting down and the aim is to share and discuss data on infectious disease, and then working together, communicating and collaborating and seeing how we can use that data to make informed decisions on how to implement our prevention measures. All right, and then lastly, discussing MedSys. So MedSys is Arizona's secure online disease surveillance system. It's a platform where you're able to report cases of communicable diseases. But what makes the Arizona specific surveillance system really unique and really helpful is that it's actually shared with Sonoran health authorities regarding infectious disease cases of binational interest. So our Sonoran counterparts are actually able to also input their infectious disease data into the system. They can track their cases of infectious disease, run reports that break down population data, and then utilize the system to follow infectious disease patients who are moving across the border. The system actually has its own secure messaging system within, and that really helps with the follow-up and care of these infectious disease patients, particularly those who are migratory moving back and forth. However, this system is definitely very underutilized at the moment in terms of actually sharing the data with one another, having those subsequent conversations about it, producing actionable outcomes. Each organization is responsible for the mandatory reporting of their infectious disease data, which is taking place, but there's a great lack of that subsequent collaboration. Like, what do we do with the data now that it's in the system, now that it is available? So our approach to handling this and the underutilization of the system, on an internal basis, moving our entire infectious disease reporting system online. So at present, the way that we report mandatory infectious disease is a bit fragmented. A lot of things are done by hard copy and they're faxed to the county health department or to AACHC. So moving all of this to an electronic basis, every single case of infectious disease that falls under the mandatory reporting requirements, I'm doing that online. So via MedSys, everything's kept in this electronic system. And then also having the infectious disease program. So myself and my team handling all of this ourselves. So really taking the burden off of our providers, off of our medical support staff to report each case of infectious disease that they come by, and remember the reporting process, submitting the faxes, all of that, just really taking that burden away and making this one of the focuses of the infectious disease program itself. So then secondly, on an external basis, what we would do kind of on the binational basis. So when we're sitting down with our US and our Mexico health partners, running reports in MedSys to really understand where we're at with incidence rates and prevalence rates of both current and then also emerging infectious disease. So because this data includes cases from both sides of the border, the numbers are discussed together and we can really understand kind of the big picture prevalence of infectious disease, what cases of what diseases we're seeing where, have outbreaks started on one side of the border and progressed to the other side of the border. And then the outcome of all of these is really ensuring a proactive and then data-driven response to infectious disease. This is occurring both on an internal basis, so how we handle infectious disease as an organization, but also on a binational basis as well. All right, and then just key takeaways regarding our binational infectious disease program, focusing on the fact that it's proactive. So really avoiding that solely reactive response to infectious disease prevention and control, taking charge prior to emerging infectious disease, not letting the emergence of infectious disease catch us off guard, if you will. And then secondly, ensuring that the program is data-driven. We're placing such a high emphasis on prioritizing the use of data and really utilizing that data at all stages of program implementation. So utilizing the infectious disease data that we procure internally, reports that we run as an organization, what's going on in our clinics, but that also using surveillance data in the United States and partnering with our colleagues in Mexico to make sure that the data shows the whole picture of our service area, not just what's happening on our side of the border. And then subsequently making sure that all of our decisions, our response, our prevention and treatment measures, all of these are informed as they are based completely off the data. All right, and then I just wanted to say one final thank you to Direct Relief and then to the Pfizer Foundation for making this infectious disease program possible. And that's all I have for today. Thank you.
Thank you, Emily, for that great presentation. I'm excited to get to Q&A later on, but really great presentation. Several synergies with what we talked about on day one of the conference in terms of what Dr. Pereira mentioned about the importance of partnerships, importance of data. So really excited about the great work you guys are doing. All right, Dr. Sumar is next. So Dr. Sumar, if you want to go ahead and bring up your slides.
Good afternoon, everyone. Just give me a minute. This is taking a little longer than I expected. Sorry about that.
No problem. We are all friends here. We understand technology is challenging.
You see my screen?
Yes, we can.
Okay. Good afternoon, everyone. My sincere apologies. For some reason, the camera is not going through and we were not able to fix it in time for this meeting. So sorry about that. My name is Kamal Sumar. I'm the Associate CMIO at Adelante Healthcare. I think all of you know Adelante. We're an FQHC here in the Valley with 9 clinic locations, offering primary care services to our communities here, including behavioral health, dental services, and WIC services. So just like everybody else was adapting to a whole lot of changes in 2020, it was definitely a year of change across the globe, across the world, and we all, dealt with it in many different ways. All the challenges that came with COVID-19 and all the quick changes and adaptations that healthcare in general had to make was obviously a lot. Along with that change came telemedicine. Telemedicine is obviously not a new concept. It has been around for a while, but definitely did not create the success story it hoped to achieve when it was, first introduced. We all know that there were many challenges as it related to reimbursements, as it related to regulations, as it related to the legal concepts around telemedicine. It wasn't well adopted, but it existed. There was something like telemedicine, which was utilized to some extent. A lot of us in the healthcare world talked about moving in the direction of telemedicine. But in the absence of this global pandemic, it probably would have taken us all many years to get there. It was something we always wanted to do, but the change to bring about within our own organizations would have taken much longer. Obviously, as we all know, with the global crisis, it just pushed everyone. It pushed the healthcare world to do a complete 180 degrees on telemedicine. It obviously then became the first thing to rush into, something that we needed to bring in place to be able to offer access to our patients to get that timely care and take care of all their needs. And at the same time, keep our patients as well as our staff and providers safe, limit exposure to disease. We all know all the many reasons that pushed us in that direction. With that change, we basically started looking at telemedicine in a whole different light. Remote consultation just became an alternate option. Safety was priority, but again, not being able to provide the care that our patients really needed was not an option for anybody at any level, be it an outpatient clinic, be it an inpatient facility, hospitals, you name it. the whole system worked alongside, right? Agencies released all kinds of guidelines. They made it easy, they made it amenable, they had fully covered services. We went through a historic expansion of telehealth services just to be able to meet these needs during the global crisis. We all know telemedicine is a ready to use option. It's been there, it's been established, it is useful, it can be utilized. It's about implementation and about adoption within our healthcare system, right? And as we talked about previously, it's always been a challenge. There was very poor adoption. Again, reimbursement challenges, guidelines. There's one element missing in digital health, which is really responding to the cultural sensitivities, which sometimes creates a perception that it's not as good as face-to-face visit. So, digital health, although it's not new, but there is still a lot of work that needs to be done in that arena where it comes to accepting cultural practices and sensitivities for patients and their patient-provider relationship. To be able to successfully implement telemedicine requires a significant lift on the infrastructure side. It's a significant investment. It's a significant upgrade to something that we were not necessarily ready for or not leveraged to be in that best position. There's a lot of awareness that comes with it, a lot of marketing, a lot of strategy. It's a lot of patient stories. It's a lot of, how can we impact care? How can we deliver care? How do we create those telemedicine skills, so to speak? There's just a general lack of awareness in the patient community as such. But with the global crisis, we were left with no option but to come up with these alternate, innovative ways to deliver care and limit exposure, keep everyone safe, and do it fairly rapidly. It's not like you had the usual 6 to 12 month rollout period or something like that. Everything had to be moved fairly quickly. Just like everybody else, we went through a journey at Adelante. Adelante did not have a telehealth platform prior to this. We had to start from scratch. We had to build our infrastructure. We had to identify what tool would work best in our given setup. We had to position ourselves fairly well for timely access to care so that our patients could get the attention they needed at the time. We all know that telephone visits were introduced, they were fully reimbursed, and that was the quickest way for us to get on that journey. We did a quick start with telephone visits. We rapidly changed our workflows. We pulled our work groups in and came up with specific workflows around telephone visits, the consents that went with it, the scheduling changes that we needed to adopt to be able to accommodate for this. Our approach was very agile. We kept changing. We all know during those early days, guidelines were changing almost on a weekly basis, sometimes every other day, bi-weekly, and we had to keep adapting to all these changes that were rapidly coming our way. There was constant need for reassessments. There was constant need to adapt to new workflows. There was constant need for training. There was constant need to remind our providers, staff, patients alike that these were the changes that we had to pay attention to. Like I mentioned, we did not have a telehealth platform at the time. So it started with reviewing all the options that were available to us as a company. As you know, there were free options, there were turnaround, turnkey options, going to fully integrated options. So we had to lay all our options out on the table and decide what was the best fit for our organization, and then proceed to rolling out of these video visits. It was definitely a time of review for us. What is in front of you is basically certain criteria. This is by no stretch all-inclusive. We had different aspects, whether it came to the product that we were going to go with, focusing again on the patient experience and what was important to the patient, and then what was important from a provider, clinic, staff standpoint. What you see in front of you are a few of the things that we considered as we looked at different products. What were the requirements to bring this platform on, in existence? What were the compliance features around it? Was it scalable? We are a fairly large mid-sized organization. Was it scalable for us as we keep growing? The setup time, the turnaround time, the cost that was involved in each of these platforms. At the patient level, we're an FQHC. We have barriers. Our health literacy is definitely a concern. So was it easy for our patients to use? Did they have access to all of these? What was the experience that they would have got in doing these visits? Broadband requirements, we know that's a thing. We know that's something that's definitely a barrier out there. What device requirements were for each of these products? Then not to forget, how would it impact our clinic, our providers, our staff? Right from the scheduling piece, right? We had to change our schedules to accommodate for these visits. What are the infrastructure, the AV requirements to be able to have these seamless visits? How could we integrate this within our workflow? We were looking for an integrated option because we know that is indirect cost involved in going with a non-integrated option. We definitely didn't want to not pay attention to that piece. Were we able to provide support to our providers, to our staff, as we started with these visits? It was a change for everyone. The billing components, the consents that were required to have in place. So there were many, many considerations and many discussions. And we got a work group together. We got a group of people from different, with multi-representation across the organization, from providers to clinic staff to leadership to our training teams, our scheduling teams, you name it. Everybody who was involved from the start to the end of a patient visit was involved in this decision. A new program comes with a new process. It's needless to say, unless we define a process, it's really hard to manage a process or to be successful, or at least head in the right direction. Our process involved schedule. Right from our call center, we have a call center that receives calls. So it was about training our call center agents to be able to introduce this program to our patients, encourage them to use this as an alternate option to see their providers in a safe manner, get them to get their needs completed by using these alternate options that we had to offer. There was a lot of scripting changes, a lot of training that went along with this to get our call center agents ready for this transition. We had workflow changes, a lot of telehealth communication skills, the ability to be able to scrub our schedules in the moment at the clinics, at the provider team, so that they could transition patients effectively between different modalities of care as needed. There was an element of patient support and navigation through our system, through using the links that we required for telemedicine. We knew there was going to be technical challenges, there were barriers that we had to be prepared for these questions from our patients and how to respond to them and what we need to do in advance to make sure that they could join the visits and so on and so forth. As I mentioned, a lot of our clinic sites needed infrastructure improvements to be able to have these audio-visual visits go on seamlessly in a manner that would fit within our workflow and not cause any disruption to the flow. There was constant changing of billing requirements and regulations around it. And it was really important to see how our patients engaged in this alternate form of care. What was their experience? What could we learn from this? It was a PDSA process. How do we make changes depending on the feedback and our experiences? Any new program requires multiple factors to be really successful. Teamwork being the number one thing. I think going through this program, we definitely exhibited a good strategy around teamwork. Our teams came together. We were just working to make this happen. Everybody worked together, was a very collaborative process, providing input and basically making changes. It was a constantly evolving process, but everybody worked through it. We got a lot of buy-in from our teams and we were able to move along. So teamwork is definitely critical anytime we have a new program or something new that we are introducing, and definitely contributes to the success or other progress with these new strategies. As you can imagine, there was a lot of strategy in the process. There were a lot of changes. What are the ideal patients that can go through a telemedicine visit? Identifying all those key factors that were important as we were scheduling these visits, et cetera. What kind of services could we offer using telemedicine? It was creating innovations all the time. Let's try this. If this works, great. If not, let's tweak it to make it work. There were a lot of lessons we learned along the way as well. Any program, any new process requires measurement. We need data to be able to show how effective we are when we have a new program. With Emily, with her presentation, she emphasized multiple times, data is key. Data really helps drive programs, and that's an experience we've had as well with our programs. We had a task force, a meeting that happened weekly with COVID at the time, where we discussed different elements, and we were reporting on a weekly basis our usage of telemedicine visits. There were weekly reports being run, starting with how many telemedicine visits were we creating to start with, so from an appointment standpoint, as well as how many were we scrubbing on a daily basis at the site level. How many of the patients were successfully completing a telehealth visit or a telemedicine visit, and how many had to be switched back and forth, et cetera. We were closely measuring all of these parameters and sharing them with the group and making changes and adjustments as needed. There was a constant comparison being made with our percentages of face-to-face visit versus our other modalities. There was a lot of emphasis on encouraging telehealth visits now that we were able to offer them. Of course, we know that some of our patients and providers were comfortable doing telephone visits, but there was a definite emphasis on encouraging the video visits for obvious reasons. As we implemented telehealth, we kept adding new features that we could provide. We offer translation services for our patients and staff through the telehealth platform. We were able to do guest add-on features so that, for those that were struggling with using that, could pull in a family member who could potentially help with that. There were branding options that we were offering and providing information specific to Adelante and our workflow via our telehealth platform, all with the intention of creating more patient engagement, so to speak. We were doing surveys at the end of all of these telehealth visits and collecting this data, looking at what kinds of experiences that our patients have. How did they evaluate these visits? What were their comments about their visits? How could we make improvements? How could we adapt to what was needed to make this a viable option? Our no-show rates were being measured constantly, and we were measuring cycle times, the time it took for the provider to spend during the visit, the staff member, the patient. So these were all key measurements that we were doing on a regular basis. And Adelante, we are very transparent with information. So this information was being shared with multiple teams and groups that were involved, getting them engaged in the process as well. This is just some of the measurements that we did, and I spoke to quite a few of them. We were talking about usage of telehealth by create date and completed visits. In addition, we were measuring the amount of time the patient spent during the visit, the provider and staff time, no-show rates, a lot of patient satisfaction scores. We were measuring broadband and Wi-Fi during the visit, just to have a complete spectrum of what was happening during these telehealth visits. Here are some wins and opportunities that we learned along the way. The wins, as we know, is keeping our patients safe, giving them easy access to care. We chose something that was integrated with our EMR to make this a seamless experience. We could rapidly deploy this platform, a lot of development of new workflows and trainings around it. As we know, telehealth addresses a lot of barriers to care. We have patients who have transportation issues. They can't take time away from work. This last year, with kids being out of school and doing online classes, that was a huge barrier in itself, no childcare. So telehealth was a modality that helped address all these barriers that our patients had. It definitely reduced the cycle time, and our no-show rates for telehealth appointments was very low. Opportunities, technical challenges obviously make the top of the list. There were a lot of them on the patient level as well as the provider level. Broadband coverage was a limitation. I talked about this briefly, the patient perception that it's not as good as a face-to-face visit. It's not as efficient. It doesn't quite do it. Was some of the feedback we received, and definitely opportunities for us. Cultural barriers that are linked with these visits, the lack of awareness. And we did realize like a lot of our patients joined these visits late. They were late for these appointments, and creating a policy procedure around that was definitely an opportunity or other challenge for us. Here are some metrics that we collected along the way. It is an average, we have months of data and still counting. An average time that the provider spent during these visits was 9 minutes and 51 seconds. And again, it's a huge range, but that's where we averaged at. The patient satisfaction score for the ones that responded to our surveys, we ended up at 9.18 on 10. There was a lot of buzz out there with, we start the visit and then we can't really complete the visit and stuff like that. And we were able to actually measure what were the issues on the patient end and what were the issues on the provider end. And we realized like some of our patients had their broadband and Wi-Fi capabilities way down on the lower end. That definitely contributed to them not having the best patient experience. And as you can see, yes, the patient did spend an average of 23, 25 minutes during the visit. But when you think about the time it takes for a patient to drive to the clinic, the check-in process, the back office process, meet with the provider, end their visit and drive back, this was definitely far more engaging from a patient standpoint. Here are some patient responses that we collected along the way. As you can see, convenience is a big thing that our patients definitely valued. It was easy to use. There was no downloads needed. It was great experience with their providers. The ones who had great visits, the sound quality, etc. The understanding of the visit was fairly good. But nothing comes without issues. And these were our opportunities, and these are all reported by our patients. Obviously, connection being the big thing. Some of our patients said they really liked the face-to-face visit. The telehealth visit is okay, but it's not quite there. Some of them had audio issues, not being able to really follow through with the visit. The wait times was also definitely a concern for some. What's the future of telemedicine? We've heard in this week itself through different speakers and stuff, and we know with all the changes, there is still a lot to be learned in this journey. Despite the challenges, we know for a fact telehealth is here to stay. It's a safe modality to deliver care to our patients. It's not going away anywhere. It's going to be here. The reimbursement for now is there. There is, we all know that telephone visits may be going away, but video visits are here to stay. And internally at Adelante, we've made a decision that starting July 1st, we will be offering video visits to all our patients. We do have the ability that, if there are audio issues or audio video issues, we have the ability to switch them to telephone visits, but we would be offering the video visits to our patients. The push is to be able to do that unless there's technical reasons to switch. Currently, we do offer a lot of our behavioral health visits via telehealth, and it's been really successful. We have 70 to 80% of our behavioral health visits being delivered via telehealth. There is a lot of value to telehealth with chronic disease visits, with primary care visits. We've actually been one of the awardees of remote patient monitoring, the HRSA grant, and we'll be starting that program fairly soon. So there is a lot of care coordination opportunities that we can offer through telehealth. Of course, in general, there has been a great access to specialists using telehealth as well. So there is a lot of role that telehealth can actually play in today's healthcare system. And I think, that's definitely going to take us in the future and be an acceptable modality of care. That's all I have. I'm happy to answer any questions that you may have.
Thank you so much, Dr. Sumar. That was great. And I feel like you set up the telehealth breakout really well. You guys are going to have a lot to talk about in that breakout. All right, so everybody is able to unmute your line. So feel free to unmute yourself and ask your question or type it in the chat. All right, looks like we got our first question in the chat. Looking at the future, do you hope to develop a telehealth RPM program for specific patient populations?
Yes. So like I said, we have been awarded the HRSA grant around hypertension and remote patient monitoring. So that's going to be our first start in that direction. And we hope that we can evolve from that experience and be able to have more of that available to our patients.
Thank you. Another telehealth question, is telehealth covered if the provider is in Arizona, but the patient normally located in Arizona is out of state during the visit?
I think at this time, everything has been relaxed, but I will have to defer to my billing team on that and I can get back for a confirmation.
Thank you. Yeah, I myself try to avoid reimbursement questions. I'm not going to touch that one. Lucy, is your question to Dr. Sumar or Emily? I'll just ask
Emily, to
Okay.
Emily or both, I guess.
Okay, perfect. Yeah, I was just
Yes.
gonna probably go to both. Did you utilize the community health worker model during the implementation? So Emily, we'll start with you.
Yeah, so right now, kind of specific to our COVID response, our community health worker team is extremely involved. So this isn't really seeping into like other infectious diseases, focused mainly on COVID at the moment, but they play an imperative role in kind of identifying our migrant and seasonal farm worker communities, low-income housing, who are in need of either COVID testing or COVID vaccinations. And then if it is a farm worker population, typically with our director of community programs and then our community health workers, they go out as a team into the field and actually provide the vaccines on site. Same with testing if that's needed. As far as expanding the roles of community health workers in a sense of all infectious diseases, like for the binational program in particular, there's a really interesting model being used across the line right now where they have community health workers dedicated to following up on infectious disease cases. So these cases are identified by a provider, they're entered into MedSys, kind of followed electronically on that system, but then they have community health workers like physically going to these patients' stores, like checking up on them, ensuring that they're continuing their medication, if they're out of medication, like why, is there a way that we can help get that to you, etc. So I think it's not happening right now, but I think it's something that would be really, really great to implement down the road, particularly for our patients experiencing infectious disease.
Will you be willing to share the contact information of the person who handles the community health worker model in your organization?
Yeah, absolutely. It's Susan. Should I share it in the chat box now?
Thank you.
That'd be great, Emily. Thanks. This is what we love to see on these sessions. So great information sharing. The next question is what Dr. Sumar, what specific platforms is Adelante using for voice and video television?
So we decided to go with Auto, that's NextGen's telehealth platform. So that's what we've been using. And we did have Zoom for our behavioral health way back when, but our behavioral health team has also transitioned to Auto at this time.
Thank you. I don't see any other questions in the chat. Emily, you mentioned at the end of your presentation that you feel like you're better positioned as an organization to be more proactive in the future rather than being reactive like you had to do at the beginning of COVID. I'm curious if there's any like outstanding challenges that you feel like still exist, and if so, have you thought through how you might overcome those?
Yeah, current outstanding challenges, I think right now, just given the state of the pandemic, a lot of effort is going to COVID response. So our infectious disease team here in Bisbee, it's a lot of running how our vaccine program works, like within the clinics, out in the community, making testing available still. I feel like it's definitely the focus of our infectious disease response right now, just because we are in a state of global pandemic. So I think that, yeah, I'm looking forward to kind of getting at a place where we have a sustained effort against COVID. It's still there, it's up and running, continuous, and we have more time to focus on other infectious diseases that are present throughout the service area. So I think that it's a matter of just having everything run smoothly, everything going according to policies and procedures. Again, not being reactive, but just having those systems set up to address concerns with COVID to free us up for other infectious disease response.
Great, thank you. And just in terms of sustaining the program, right? You mentioned that a lot of this work has been grant funded. Do you feel like what you're putting in place is sustainable long term?
I do think so. I think that was one of the, when our CEO wrote this grant, he really wanted to focus on the aspect of sustainability. I think it can kind of be spoken about in two different senses. So sustainability of the infectious disease program in general. It's definitely here to stay. I think given COVID, like it was just very, very much realized that we needed an individual, a team dedicated to infectious disease response in the organization. So I think this team in general will be sustainable, continue on addressing infectious disease throughout the county. And then as far as the binational side goes, I did touch on it, I think, a bit in the slides. There have been other efforts to kind of form like a committee talking about infectious disease or other health issues in the States and then in Mexico as well. And these committees tend to fall apart a bit due to changes in political environment. So that's one of the main things that Alex, our infectious disease binational liaison, is focusing on, just making sure that everything is set up with the proper authorities, politically speaking, on the Mexico side, so that those who are involved with the actual efforts, the epidemiologists, the providers, the health directors that are sitting at the table, they're allowed to continue to participate. And it's a recognized effort at a high level in the country.
Great, thank you. Okay, we have time for one more question. Were there, and this is to Dr. Sumar, were there any challenges with the adoption of telehealth processes, such as sign-in for providers during the transition? If so, how did you make that smoother to maintain buy-in?
So it was definitely work in progress. There were challenges, many of them, right? We had some that were good early adopters and they really did utilize it much better than others. We had some that couldn't really get on it. So we kept reviewing these very closely and moving these licenses around so that we could adjust our usage and make it more comfortable for our providers. We did make some changes in terms of equipment, et cetera, to make it a little more user-friendly for them. That would help with buy-in. But I think it was more about, just like anything else, the more they used it, the more comfortable they got with it. And keeping it constantly as a form of discussion and encouragement, I think helped with some stability around usage.
Great, thank you. Thank you both again, Emily and Dr. Sumar, for your fabulous presentations. We are going to transition directly into the networking